Welcome to Echocardiography Lecture Series. This episode contains a case to consolidate the information that we learned from the previous presentation of hemodynamics. So let's begin. So let's start with the case. The case is 35-year-old lady. She's complaining of shortness of breath for 2 months and echo is requested. This is the first image, and as you can see, her LV appears a little bit dilated. Maybe the walls are thickened. Mitral valve is abnormal. It appears thickened, and maybe there is diastolic doming. Similar thing to aortic valve thickening and diastolic doming. So even if we cannot see it, maybe we can try to pause. And if we pause here in diastole, you can see that the mitral valve, let me just bring the pen. The mitral valve here has diastolic doming, so it is domed. It does not open like a straight line. It has a doming like this, or hockey stick appearance, and this is consistent with rheumatic mitral valve. If we play again and proceed to the aortic valve, we will see almost the same thing happening in the aortic valve. Thickening, maybe a little bit of doming, so it's abnormal, and most likely the process here will be rheumatic. If the mitral valve has a rheumatic process, so likely the aortic valve has also a rheumatic process. Divided by 2. When putting a colored Doppler, we will notice, which is definitely looks like a severe aortic regurgitation, and also there is some eccentric mitral regurgitation going posteriorly in this direction. So this is a posterior mitral regurgitation. So eccentric mitral regurgitation can be underestimated due to the wall hugging effect. But if you look at the aortic valve, there is no doubt that this aortic regurgitation is severe. Moving to the next slide and looking at the aortic valve in short axis, and this is how a rheumatic aortic valve will look like. You will see commissural fusion. So the commissure, or the area between two leaflets, the opening between leaflet, will be fused and thickened, and also you will have thickening at the leaflet tips. So here at the coaptation line, you will see some thickening. Coaptation line here, it will be thickened, and you have commissural fusion here and here. This is typical of rheumatic process. By adding a colored Doppler, we can see that the regurgitation is coming from within the coaptation line, or in the commissure. It's not within the leaflet, so there is no perforation. So it's coming within the coaptation line. So there is a problem in the coaptation. Continuing with the study, this is a short axis at the level of great vessels, and we can see the pulmonic valve here. It's competent. There is the normal physiological regurgitation, and it doesn't seem to have any other or any pathology in the pulmonic valve, which is a good news. Again, now looking at the mitral valve in short axis, we will see almost the same process. You can see here that there is thickening in the mitral leaflet tips, and there is some commissural fusion here anteriorly and posteriorly, or lateral and medial commissure. And also you will notice that the mitral valve opens fairly well. We're not expecting significant stenosis, but we have to quantify or to grade this stenosis. Having a closer look at the mitral valve, we see everything clear, and this is a definite traumatic process. By continuing the study, here we have a surprise. We have an interatrial shunt. It's from the left atrium here to the right atrium here, and this is the shunt. By looking at the shape and the direction of the flow or the shunt, it is likely an ASD. A PFO is still valid differential diagnosis, but having this image and this direction of the flow, it's likely to be an ASD of secondum type. LA is dilated. The LA volume by biplane is 108. If we index it, also it will be within the severe range. So to summarize our findings, we have aortic regurgitation or aortic insufficiency, AI, which is likely severe. We have mitral regurgitation. Maybe it's mild to moderate. We might have some degree of mitral stenosis. And we have an ASD. So now our job before sending the patient for the treatment, we need to quantify aortic regurgitation. We need also to quantify mitral regurgitation, mitral stenosis, and the ASD. As an echocardiographer now, this is our job to give a full report of that. We will have a few dilemmas and difficulties, but we have to try to overcome it because we have multiple pathologies. It's not easy to quantify it when we are having multiple pathologies. For example, let's start by quantifying aortic insufficiency. So how we can do that, if we have the pulmonic valve stroke volume and we have the aortic valve or stroke volume through the aorta stroke volume, the difference between them is the regurgitant volume. Ideally, the aortic valve will send stroke volume maybe 100 ml. Some of it will go back and regurgitate back to the LV. The rest will reach the right side, and from right side it will come out of the pulmonic valve. However, in this scenario, our pulmonic valve here is normal. There is no insufficiency, so we can use it. But we have another problem, which is the ASD. So the problem here is pulmonic valve, or the stroke volume of the pulmonic valve is equal, it equals the stroke volume that reaches from the left side, let's say left side stroke volume that reaches the right side, plus the shunt that came from the atrium. So plus the shunt volume. So it means we cannot simply use this pulmonic valve to get the aortic regurgitant volume. Another way to get the aortic valve regurgitant volume in order to quantify the aortic valve regurgitation is through the mitral valve. So whatever volume will go through mitral valve has to go out from or through the aortic valve. So let's assume that 50 ml has left the mitral valve and 100 has left the aortic valve. So the regurgitant volume is the difference between both valves, which is 50 ml. However, we have mitral regurgitation. So some of that 50 will reach the aortic valve and the other volume will regurge back to the left atrium. So we cannot use simply the mitral valve to get the aortic valve regurgitant volume. So what are our options now to quantify the aortic valve? If we have a PISA through the mitral valve, we can exactly know the regurgitant volume. However, because the flow is really eccentric, it will make the PISA a little bit difficult. So looking at the mitral regurgitation here, we can see the mitral regurgitation appears a little bit more than mild, and it's really eccentric. We might not have much of PISA, but we will try. So this is the PISA of the mitral valve, and we can see the radius here is around 0.4 centimeter or 42 centimeter. We will get by applying the PISA equation an effective orifice area of 0.05 square centimeter, which is consistent with mild mitral regurgitation. If we proceed to the Doppler of the mitral valve, we multiply the VTI here, which is 255 centimeter, times the effective regurgitant orifice area that we got, which is 0.05, and then we will get a regurgitant volume of 13 ml. However, we have to be a little bit careful because the jet is eccentric and the jet density here is not very encouraging. Now let's get the stroke volume through the aortic valve. I measured the LVOT of 2.35 centimeter. That will give us a stroke volume of 99 ml if we use this VTI here, which is 22.8 centimeter. Now let's go back to the mitral valve. If we go to the mitral valve and we measure it correctly, and we measure it from the insertion to the insertion of the leaflet, we got here a number of 1.9. So that diameter will give us, if we calculate for a stroke volume with this VTI of 11.18 or 11.88, we will get a stroke volume of around 33 ml. So out of that 33 ml, we know that from the PISA that 13 ml is the mitral valve regurgitant volume. So 13 ml will go back, and the rest, which is 20 ml, will join the aortic valve regurgitant volume and will come out through the LVOT. Okay, so just let me erase that. So the aortic valve stroke volume, or LVOT stroke volume, is 99 ml. Out of that, 20 will go out and the rest will come as a regurgitant volume. So the aortic valve regurgitant volume will equal 79 ml. Because whatever comes from the mitral valve after deducting the mitral regurgitation, it has to join the aortic regurgitant volume and leave. The regurgitant volume will come back through the aortic regurgitation, and the volume that came through the mitral valve will proceed to the right side, which is now 20 ml. So the regurgitant volume is 79 ml. Luckily, the sonographer has managed to get a good piece of the aortic regurgitation, and this will make our life really easy. We have a good vena contracta here and flow convergence zone. So the PISA radius here is 0.9 centimeter, and when we plug all the numbers, the velocity and the piezo radius, we will get an effective regurgitant orifice area of 0.47 square centimeter and regurgitant volume of 76 ml, which makes a perfect sense. So let's summarize now what we have. We have mitral valve, regurgitant volume 13 ml, and mitral valve stroke volume of 33 ml, aortic valve stroke volume of 99 ml, and aortic valve regurgitant volume of 76 ml. We got this 76 ml from the piezo of aortic valve and continuity equation. We got 79 ml, which almost identical, so it will make us more confident that this is almost the exact or correct number. Now let's go to the right side. If we go to the right side, this is the RVOT. We measured the diameter just proximal to the pulmonic valve. We got a diameter of 2.18 centimeter. We have also a spectral Doppler just on the exact area where we measured the diameter. That will give us a right side stroke volume, so RVOT stroke volume of 41 ml. Okay, by knowing that, we know also that from the left side we have 99 ml stroke volume. Out of that 99, 76 will be regurgitant volume to the LV, so we have 23 ml will reach the right side. So out of that 23 ml that reaches the right side, it will exit 41. So 23 will reach, but the exit is 41. The difference must have come from the shunt side, the interarterial shunt. So the difference, 41 minus 23 equals 18. So 18 is the shunt volume here. Now we need the QPQS. QPQS will be 41, which is stroke volume from the right side, divided by not 99, no, divided by the true volume that will exit the aorta, and it will never be regurgitant back. So divided by 23. That will give us a QPQS of 1.8 to 1. QPQS now is 1.8. So now what we know about the mitral valve? We know that the mitral valve regurgitant volume is 13 ml. And also we know that the mitral valve stroke volume is 33 ml. So regurgitant fraction here will be 39%, which is 13 divided by 33 times 100 is 39%. Because we are dealing with a small volume, because we have a lot of pathologies. We have severe aortic regurgitation, we have significant interarterial shunt. We don't expect to have a huge volume as a reflection of true severity of mitral regurgitation. So if we go by regurgitant fraction, it will be in the moderate zone. Regurgitant volume, it will be in the mild. So we'll go by regurgitant fraction because it has the upper hand over the regurgitant volume. Now, the mitral valve stroke volume is 33 ml. So 33 ml will pass through this VTI here, which is 15. That will give us an area, mitral valve area of 2.2. If we divide the volume by the VTI, we will get the area. So 2.2 square centimeter. So let's summarize our findings. We have a severe aortic insufficiency with a regurgitant volume of 76 ml and regurgitant fraction of 80%. We have a mild to moderate mitral regurgitation. The regurgitant volume is 13 ml in the mild zone. However, the regurgitant fraction is 39%. We have also progressive mitral stenosis with mitral valve area of 2.2 square centimeter, and also we have an ASD with QPQS of 1.8 to 1, and that will complete our report in this case. I hope you enjoyed the case of some hemodynamic calculation.